everyone. So I think we should start now. We are already late by half an hour. So this course is a postgraduate course basically in nephrology, but we every time pick up one theme topic and have our deliberations on that topic. So this time the theme is essential hypertension, which is a very common and a very important problem for the society. So as a nephrologist, I think we must understand what is the pathophysiology and how one should go about treating it. So to start this course, I will invite Dr. Ajay Kher. I don't think he needs any introduction to this audience. He will get the course rolling because he was the main person who planned this course, the content of this course.
Thank you, Dr. Singhal. So I think I'll kind of just share a little bit on hypertension as it is, and as was just being discussed, I'll share a couple of patient stories from just the last week. And this is something that all of you will see on a day-to-day basis as well. So I just saw a 40-year-old male who came in to me for a creatinine of 2, but had a blood pressure of 180 over 100. And when you talk to him, he says, oh, I have had high blood pressure for more than 10 years, so which is at the age of 30. And over the last 10 years, my blood pressure has never been less than 160. I've seen multiple physicians. I take 5 to 6 blood pressure medicines, but my blood pressure has never been less than 160. And I have now reconciled with it कि 160 के नीचे तो आ ही नहीं सकता है. So that's one patient. Then next one, 65-year-old female, 5 years ago was told that she has a single functioning kidney and her blood pressure at that time is 160. Unlike the first patient who's gone and seen multiple physicians, this person didn't realize the implication and stayed home. Now 5 years later, she is coming in with uremic symptoms, nausea, vomiting, and lo and behold, her creatinine 6. So I think one of the things that I take home from this is that this is our territory. Hypertension, unfortunately, as we were just saying, is something that is critical to us, and I think we need to start taking more and more ownership of hypertension, not just for our kidney disease patients, but also for hypertension in the general public. And do it for the patients, do it for the physicians and general medicine physicians as well, and make it an outreach from our side that this is something that we should also be taking ownership of, rather than just giving it to the cardiologist or general physicians. And to do that, we need to own it, we need to know about it, read it, be up to date on it, and then only we will be able to project out to the general public as well as to the physicians who we interact with. So I think that is something which I hope from this focus on hypertension that you guys go back to the daily practice that we do, and as you go on in careers, that this is something that is ours and we need to take ownership of it. So that's, I think, one thing that I hope you take from the session today. The second thing that I would want you to take home is the method of how this session is created, and it's an intentional method where we want the students themselves to take a topic, read about it, learn about it, and then teach it. And for me personally, this is the only way that I learn things, is either whatever I get, when I pass it on, that's when things get really, really clear for me and I learn and those things get ingrained, versus I hear something and then it kind of falls off in a day or two. The second method is from patients. So you see a patient, you read, you learn, and then that stays with you. So I think those are the two methods. So what I hope that you guys take from this also is that method of how do you continue to learn as you go on in career, because no one's going to be sitting behind you. As a student, yes, there are teachers here who will be pushing you, but as you go on in your careers, it has to be self-learning. And you have to pick up which method works for you and then use that to kind of grow. Third thing that you should take is listen to everyone's talk, not only for the medical content, but also what and how it impacts you and what all you take, because you will see each person will have a different method, a different slide set, a different way of delivering that content, and what you can take is, okay, this one was the most effective. Why was it most effective? What were the things that they did? So that as you see effective teachers, effective people who give talks, how can you get better on it as well? And what is a good talk? So I think those are the three things that I would hope that you take from this session. One is hypertension is ours and we need to own it. Second, how do you learn as you go on? And then the methods so that you can get better at that as well. So I think with that, I will invite Dr. Pooja Lokur for her first talk on one clip, two clip models and what it tells us about the mechanism of hypertension.
You can remove your mask.
Pathophysiology of
Your mic. Put the mic closer to yourself.
Good morning everyone. I will be presenting the pathophysiology of hypertension, mainly with the emphasis on the role of one kidney, one clip and two kidney, one clip models. My mentor is Dr. Ajay. To start off, the pathophysiology of hypertension is a very nice story to how it got related to the kidney. So in 1836, Richard Bright for the first time linked renal disease to left ventricular hypertension. Thereafter, in 1898, Tiggerstedt and Bergman discovered that extracts from the kidney, from the ischemic kidney, when injected into rabbits, they found that they had pressor effects on the whole animal. This compound was not known at that time, but they named it renin because it originated from the renal system. Thereafter, in around 1932 to 1934, Goldblatt conducted extensive experiments on animal models with dogs as his subjects and determined that reduced renal perfusion can cause hypertension. So Goldblatt was initially a surgical resident. So at that time, he had seen many patients who had renal diseases and had developed azotemia and hypertension in their last few days. However, in around 1916, he saw a patient for whom they had operated for a renal mass in the lower pole. So when they removed this mass, they realized that this was a single horseshoe kidney that they removed. So this person was left with no kidney at all. So just like the other patients that he had seen, he expected this patient to develop hypertension and azotemia towards his end. So Goldblatt was in charge of this patient in his last few days. He noticed that this patient developed azotemia but did not develop hypertension. So that is when he realized and he put it in his mind that no kidney, no hypertension. So he conducted several experiments. This is his paper that was published in 1934, Studies on Experimental Hypertension, the Production of Persistent Elevation of Systolic Blood Pressure by Means of Renal Ischemia. So between 1932 to 1934, Goldblatt used dogs of various breeds and he introduced...
This is probably going to be more visible if you, especially these lights. You switch off. Quickly carry on. No, I thought the pictures got looked at.
Lights need to be dimmed for sure.
Okay.
So he used dogs of mixed breeds, adult, female, well-grown dogs, and he introduced a clamp that, this is the picture showing the clamp that he used made up of silver, and these were introduced retroperitoneally. Then he meticulously conducted experiments for about 15 months and more by causing various degrees of compression of the renal arteries. So these are some of these findings of his experiment. Initially, there was complete occlusion of the left renal artery that was caused, and this increased the systolic blood pressure as per the graph shown. And subsequent complete occlusion of the right renal artery caused a peak blood pressure that was about double the mean blood pressure of that animal initially. This animal finally developed convulsions and death. Later on, he constricted the renal artery severe but not completely. He constricted both the renal arteries. There was a gradually increasing blood pressure for about 11 months. Then over the next 4 months, he observed that there was a tendency for the blood pressure to lower. And however, the animal was alive with a systolic blood pressure of more than 60 millimeters of mercury above its baseline. Then a moderate constriction of one renal artery increased in a next animal caused a increased systolic blood pressure, and then a gradual tendency to lower the blood pressure, and subsequent moderate constriction of the other renal artery also caused further increase in blood pressure, and there was a tendency for this blood pressure to fall, and a further constriction of both the renal arteries increased the blood pressure. So this is the tabulation of his findings, where the initial few days he measured the blood pressure in the carotid for different animals, and the same after constriction of the renal artery. Here we can see the mean blood pressure initially would have been in the range of 146, however it rose to around 200s after constriction. So at the end of his experiments, he also tried constricting other major arteries, the splenic artery and the carotid artery, and he found out that the constriction of other great arteries did not result in increased blood pressure. However, constriction of the main arteries of both the kidneys resulted in persistent hypertension for as long as 15 months. At that time, the exact pathophysiology of this was not known, so he put forward probable mechanisms by which the blood pressure was increasing. So one of the possible mechanisms was the afferent impulses from the affected nerve endings in the ischemic kidney led to generalized vasoconstriction due to sympathetic overactivation. Another important possible mechanism was the afferent impulses from the ischemic kidney may in some way bring about increased output of some internal secretion by which whose peripheral or central action there is a generalized vasoconstriction. So after Goldblatt conducted these experiments in 1932 to 1934, by around 1936, two different groups, one from Indianapolis and another from Argentina, found another vasoactive substance by the action of renin, on which led to again vasoconstriction in general. So one group named it as hypertension, the other group named it angiotonin. Later on, this name was combined and was put forward as angiotensin. In 1938, Pickering and Prinzmetal evolved these clamps into clips and conducted further experiments on rabbits. And 1939, Wilson and Byron adapted these techniques and conducted the experiments on rats. So this is the timeline, what we call as renovascular hypertension now. 1930s is where the experimental model started off, and by around 1980s, ACE inhibitors and reperfusion studies were conducted. Coming to the two kidney, one clip model, it is here equivalent to a unilateral renal artery stenosis. It is mainly angiotensin 2 dependent hypertension with no sodium or water retention. In this model, that is, there are two kidneys. One is the stenotic kidney on which the clamp is applied. Here there is decreased perfusion to this kidney, and thereby the juxtaglomerular cells produce renin, and this renin dependent RAS action predominates in this initial phase of the hypertension. During this phase of hypertension, in the two kidney one clip model, the pharmacological blockade of the RAS system or removal of the stenotic kidney can promptly normalize the blood pressure. Next comes the transition phase, which mainly differentiates the two kidney one clip and one kidney one clip models. So here there are two kidneys. One is the stenotic kidney, which is producing renin, and then there is a contralateral kidney that, because of the this renin is mainly produced here to maintain the intraglomerular pressures. So the contralateral kidney, which is normally functioning, causes pressure natriuresis and thereby decreases the renin production and reduces the pressure effects of the RAS system. So a state of new dynamic equilibrium is attained. This is called the arterial pressure allostasis. So at this point, the arterial pressure is at a higher level, and there is the reduced renin production by the compensating contralateral kidney. So at this point, ACE inhibitors or ARBs or removal of the stenotic kidney may or may not reduce the BP, and even if it does, it will not be as quick or effective as done in the initial phase. So this is a graph that shows the arterial pressures. The first diagram shows a clamp distal, the distal arterial pressure that is in the renal artery distal to the clamp, which is very low, and then a corresponding aortic pressure, which is high. So here, and the next diagram shows the urinary sodium excretion, where the stenotic kidney, because of its low perfusion, is not excreting any sodium, whereas there is an increased sodium excretion due to pressure natriuresis from the contralateral normally functioning kidney. And the plasma and the renin levels at both the kidneys again is different. The stenotic kidney is producing very high renin, whereas the contralateral kidney is not is decreasing the renin production. But then comes the chronic phase. So where the contralateral kidney is also starts getting affected, mainly due to increasing intraglomerular hydrostatic pressure. Here there is overactivation of the intrarenal RAS system, where there is an increase in the angiotensin of the compensating kidney. This is a renin independent mechanism. This angiotensin in the contralateral kidney is mainly due to progressive endocytosis from the circulation during the initiation phase and intrarenal synthesis of the angiotensin in the contralateral kidney. At this phase, there is failure of clipping or removal of the stenotic kidney. This removal will not cause any decrease in blood pressure. So this 2 kidney 1 clip model, which is equivalent to unilateral RAS, is not dependent on sodium retention. Hence, low sodium diets in these patients will not decrease hypertension. And this activation of the RAS system is mainly started off to maintain the intraglomerular pressure of the stenotic kidney, however causes pressure natriuresis from the contralateral kidney. So in this model, there is a closer association between the renal vein renin activity from the ischemic kidney and the BP as compared with the peripheral plasma renin activity and the blood pressure. So again, these are the phases where the first one is renin dependent and the chronic phase becomes renin independent. So next is the 1 kidney 1 clip model, which is equivalent to bilateral RAS or bilateral renal parenchymal disease. Here the pathophysiology of hypertension is mainly volume and sodium dependent. So neither sodium depletion or angiotensin blockade alone will cause decrease in blood pressure. However, a combination of two may decrease the blood pressure. So in this model, an initial constriction is applied on the single renal artery or bilateral in a single renal artery of a single kidney or bilateral renal arteries when there are both kidneys present. The kidney senses a fall in the arterial pressure and thereby increases renin secretion. So this corresponds to the early rise of blood pressure as shown in the yellow graph. The yellow graph shows an early rise in blood pressure with a sudden drop in the BP distal to the clamp, and a corresponding blue graph shows a surge in renin levels. However, this sudden rise in BP can transiently improve the perfusion of the beyond the stenosis, and later on there is a angiotensin and aldosterone system that comes into picture. This, and there is also there is no normal functioning kidney that can cause pressure natriuresis, so there is no loss of sodium and water. So there is accumulation of volume and sodium, and this late rise in BP is mainly volume and sodium retention mediated. So this is a flowchart depicting the same. So increased renin will increase the angiotensin 2. Angiotensin acts by both increasing the total peripheral resistance by vasoconstriction and also increases the aldosterone, thereby increasing the volume in the patient. This increased volume will later on decrease the renin production, decreases the plasma renin activity, but maintains the hypertension via the volume. So mainly due to sodium and volume overload, and the main point here is there is the lack of a functional kidney that can throw out this excess sodium and water. So in comparison of the two models, the unilateral renal artery system, renal artery stenosis, that is the 2 kidney 1 clip model equivalent, is mainly angiotensin 2 mediated. Here the RAS blockade can lead to decrease in arterial pressure and also enhances the lateralization of diagnostic tests like captopril enhanced renin. Whereas the bilateral renal artery stenosis or a bilateral renal parenchymal disease is mainly volume expansion mediated disease, and here RAS expansion will not, RAS blockade will not decrease the hypertension. So studies that have been done as comparing the 2 clip and 1 kidney one clip and two kidney one clip model show that the plasma renin activity is high in the two kidney one clip model equivalent to the unilateral RAS, whereas plasma volume and sodium are higher in one kidney one clip model where there is no normal functioning kidney to throw out this excess sodium. BP response to sodium depletion occurs mainly in the one clip one kidney model, whereas BP response to ACE inhibitors occurs mainly in the two kidney one clip model. So this is a graph depicting the plasma renin concentration in two kidney one clip model. Here the plasma concentration of renin is high as compared to the one kidney one clip model where the volume increases and thereby there is a negative feedback for the RAS system and the plasma renin activity falls. So animal models of hypertension, the initial animal models were of constriction of the renal artery that was done by Goldblatt, or the constriction of the parenchyma is done by Page, that is Page kidney. These represent only a small fraction of human hypertension. However, models for primary hypertension are more difficult to develop, and the validity and utility of the blood pressure in animal models is compromised also by use of different techniques and the stress and involving of anesthesia which has to be given to these animals. There are both small animal models and large animal models, and small animal models are useful in the fact that they can target specific factors in the pathogenesis. Hence, they are more useful in targeting specific genetic models in essential hypertension, whereas large animal models are more anatomically and physiologically similar to human beings, but their genetic modification is difficult in these animals. So RAS also involves other mechanisms. One is the endothelin system, where endothelin 1 acts on both ETA receptors and ETB receptors. ETA receptors increases the blood pressure by way of vasoconstriction, mesangial proliferation and catecholamine release, whereas ETB receptor activation causes a hypotensive effect. And angiotensin-induced gene transcription upregulates this endothelin synthesis. Endothelin in turn again increases the secretion of other vasoconstrictors including angiotensin, thereby increasing the blood pressure, and in renal vasculature arterioles express mostly ETA receptors. The sympathetic nervous system is also stimulated by the RAS system. In rat models with two kidney one clip and one kidney one clip, there was found to be an elevated plasma noradrenaline level, and angiotensin 2 was found to be the key mediator contributing to the overactivation of sympathetic nervous system, mainly by activation of the postganglionic sympathetic neurons and also by its action on the central nervous system. Recent studies have also shown that angiotensin is involved in inflammatory and fibrogenic mechanisms. There is an indirect stimulation of the inflammatory processes by upregulation of the nuclear factor kappa B in monocytes, macrophages and endothelial cells, and also excessive release of TNF alpha and IL-6. It is also pro-fibrogenic cytokine and increases the renal interstitial fibrosis also by action of the TGF beta. Newer experiments have shown that there is increased oxidative stress caused by angiotensin by the RAS system. Experiments have shown that slow infusion of angiotensin, other than causing an increased blood pressure by itself, also causes slowly progressive increase in blood pressure by intensification of the oxidative stress within the central nervous system in the areas that control blood pressure. This is mainly by overactivation by the NADPH and impairment of the mitochondrial function by accumulation of hydroxyl radical and hydrogen peroxide. This dominant role of the RAS system and angiotensin 2 hyperactivity is the transient mechanism by which increase in blood pressure occurs, and this is the starting point for initiation of other mechanisms including excessive oxidative stress. The GP91 Fox knockout mice model has shown that there is less severe hypertension when this oxidative stress is removed. So these are some of the other actions of angiotensin 2, that is other than sodium and water retention and vasoconstriction. It also increases the sympathetic nervous system activity, the endothelin system activation, increase in oxidative stress, and increases the pro-inflammatory and fibrogenic mechanisms, thereby leading to both increase in intravascular volume and remodeling of the kidney tissue, leading to renovascular hypertension and ischemic kidney, thereby can lead to finally chronic kidney disease.
Questions from the audience?
understanding of these models, animal models, help you to manage your patients? Say, renal artery stenosis. How does this help you to manage your patients? So give a context of clinical context to what you just said. So it's been very good. I must compliment you for an exceptionally good talk. Having read that original gold flat paper, but how did that paper help you to say in your day-to-day practice? Day-to-day practice, you're not going to talk about these flips and other things, but how does this whole thing allow you to manage your patients or understand your patients better? The decision of should you allow somebody to do angioplasty or not to do an angioplasty? Should one kidney be removed? Ischemically. There is one single renal artery. That kidney is non-functional. So how does that help you to decide should you do this nephrectomy and or not do this at all? So give a context to this talk.
So for example, if sir told about one patient who was a 40-year-old male requiring multiple antihypertensives for control of blood pressure. So even a young person requiring with resistant hypertension requiring multiple antihypertensives, in case we, like in patients presents to us early, like in the 2 kidney 1 clip model where in the initiation phase and the transition phase it is mainly renin dependent, and that time if the nephrectomy is done or early revascularization such that the initial phase, that is if it is done, this can probably treat the hypertension, whereas in an elderly
That's not necessarily right. See, when you put a clip on the animal, you know the day and the time the clip has.
in humans that is the problem, that
So
we do
in
not know when it
humans, in
starts.
that child, you don't know when did the renal artery stenosis start.
Off.
So you will never be able to decide that is this an early phase in real sense, or is it a maintenance phase, or is it a chronic phase at that point of time? So it's going to be extremely difficult in humans. That's the reason. That's the limitation of this model for direct application. In animals, you can remove that in the acute state and the hypertension is gone. But in humans, the problem is that you don't know when has hypertension started. So therefore, this tells you that you said that the other kidney may have already had an effect. Now, if you remove this kidney, the other kidney may have already had effects of hypertension and may continue to
Dysfunction and
reduce hypertension, may not allow hypertension to be cured at all. So all this will have to be taken into a context when you interpret these applications directly into a patient. And this comes on a day-to-day basis in your clinic, because somebody has said that if I remove this kidney, I recently saw a patient who had gangliomas actually. One of them was onto the left renal artery. The left renal artery, as they tried to remove these gangliomas, the left renal artery became ischemic and this kidney is now gone. But she's had hypertension for 20 years. Now, somebody is saying that, okay, I remove this left kidney, the hypertension might be cured. The chances that this hypertension is going to be cured for somebody who's had this hypertension for 20 years is very unlikely. That. So I would see, unless, of course, you may have to take this decision depending on if this patient, 20 years old patient, is requiring 4 drugs to control hypertension. Now, a 20-year-old child going to take 4 drugs for life, then you will have to weigh. Could it be that I can decrease the number of drugs that the patient may have to take to 1 and then maybe probably 2 months? So you will have to context this into this kind of an application. So animal experiments are extremely useful, and you get amazed at the amount of insight Goldblatt had, and the discussion when you read in that paper is amazing. That this guy is even thinking of that there is a secreting something. At that time, nothing is known about this. But he believes that probably something, either the neurosympathetic system or there is a hormonal system which is active. And as you have shown, further studies have documented over the next 40 years that all of these are possible. There is a neurosympathetic activation, there is also in addition a hormonal, renin-angiotensin, which is not only in the kidney but even elsewhere in the body as well. So all these get activated. And these models sort of give you that how a surgical resident who is not at all concerned about hypertension, and look at our surgeons and all that, but look at where he went. The surgical resident went into hypertension and created history, which is now being sort of talked about by nephrologists at this point of time. You get really amazed at how people have that kind of direction and inquisitive mind, and that's what. So it's amazing.
The thing is, like, these are the experimental model where you can create hypertension by renal mechanism. Can we extrapolate these models to essential hypertension? Essential hypertension, there is no renal stenosis as such. So we still believe that essential hypertension is maintained because of renal mechanism. So thus this insight gives us an idea how essential hypertension starts and how it is maintained. Because
The initial increase in blood pressure will cause pressure natriuresis because there are normally functioning kidneys, but in a more chronic phase when there is damage of the renal parenchyma, the hypertension becomes more volume mediated. So probably when there is renal parenchyma disease when we know that it is more volume mediated, the addition of diuretics or salt depletion, like they have said, or addition of diuretics are required in treatment of resistant hypertension.
So, like initially people think that there is something which triggers. There may be genetic influence, there may be sympathetic nervous system overactivity, or other hormonal mechanism which will give you an intermittent type of increased activity or high aortic pressure. And that, if continue to happen on a long time, it will create changes in the kidney. These are microvascular changes which will be akin to renal parenchymal disease, and that will probably maintain hypertension. So many factors can initiate hypertension, but it is only the kidneys which will be maintaining it. Sustained hypertension is through renal mechanism. And that's why we believe that even essential hypertension is renal. There are subtle changes in sodium and water handling, and that maintains hypertension in these patients.
No, I think that I would agree 100% that unfortunately nephrologists themselves don't believe that essential hypertension is a renal disease, and it's sad. Ajay was talking about the recent patients that he saw, but I see patients and their relatives develop hypertension and they tell me who should they go to, and they don't feel that I am the hypertension. So they ask me, should they go to which cardiologist should they go to see this, and that's basically because we haven't been able to create this. And I think what Manoj was saying is very, very true, that essential hypertension is a renal disease. There's no doubt about it. There's a lot of epidemiological evidence to that. Normoalbuminuria, which is less than 30 milligrams of albumin. 5 to 30 milligrams of albumin, there is a study which is available, I think in Japan, and there's another country also. Progressive increase in this albuminuria. So people who had albuminuria of 5 milligrams, 10 milligrams, 15 milligrams and 30 milligrams, and then obviously progressively into a moderately increased albuminuria over time. But when you create these patients, and 10 to 15 years later, look at them, those who have increased albuminuria, going even from 5 to 30 milligrams. 5 has less chances of developing hypertension, 15 or 20 and 30 have increased levels. So even in this, it's again an innate kind of a inkling which tells you that probably kidney is the origin where blood pressure. And these are people looking at 20 years later on. They found that there's obviously an increase in kidney disease also in them as they have increase in protein. But it tells you that this is, and I'm sure there are topics in this over the end of the topics, you will realize that how hypertension evolves around the kidneys and all that, and I think there are topics which will highlight that.
Yeah. So I think on the same point in terms of how do you use it in day-to-day life. So the two really classic models that you talked about, the one clip, one kidney versus two kidney, one clip. In real life, we'll see it in fibromuscular dysplasia, which would be the classic, or in the elderly with atherosclerotic renal disease. So those would be the two kind of human faces for this. And in those situations, you would also want to consider where and how do you want to use stenting in them as well. And so again, depending on how long it is, you can see the results of the stenting trials. In atherosclerotic disease, not great outcomes. But in fibromuscular dysplasia, in selected patients, you will get great outcomes. And again, it is going back to what Goldblatt saw. If it has been there for many years and the clips and the impact on the contralateral kidney is there, then the outcomes are not any better. So I think those are kind of how you link the animal studies to kind of human outcomes and human studies that we've done as well. So I think that kind of links everything together. Thank you very much, and we'll go to the next speaker. And the next talk is going to be on the pathophysiology of hypertension, salt sensitivity, and non-osmotic sodium storage by Dr. Nikhil from India. Yeah.
Good morning, everyone. I'm Dr. Nikhil, Senior Resident in the Department of Nephrology from AIIMS, Delhi. In continuing with the previous lecture, we will now see something about salt sensitivity in hypertension and the non-osmotic storage of sodium. So we'll be going through this seminar with the following outlines. First, we'll be discussing about the sodium homeostasis. So salt as a whole is an important part, and it has important impact on the human health. And whatever salt we consume, almost 100% of it is absorbed by the GI tract. As we use the teaspoon that we use in our daily life is of 5 grams of salt, which is equivalent to 2 grams of or 87 millimoles of sodium. The human body stores around 250 grams of salt in the body. The salt is an important has various important biological roles. The most important being in the osmoregulation. Maintaining this homeostasis of salt is a very complex process in which kidneys play a very important and central role. So this schematic representation overall represents how the salt homeostasis is maintained in the body, wherein the representation itself we can see that kidney plays a very central role. So right from the salt consumption, which will stimulate the baroreceptors, which will again stimulate the central nervous system, which will act on the kidneys, and through various mechanisms like the sympathetic nervous system and the RAS system, it will cause the sodium retention and ultimately leading people to develop hypertension. So what is the role of kidney? The role of kidney is to basically maintain this reabsorption of sodium. So the reabsorption of sodium occurs at different levels in nephrons, with 2/3 being occurring at the proximal convoluted tubule and around 5 to 10% occurring in the distal tubules. This 5 to 10% that occurs in the distal tubule is what is required for the fine tuning of this sodium homeostasis. In the distal tubule itself, the main role of this renin-angiotensin system is seen, where it will act on the principal cells. On the principal cells, it will cause activation and recruitment of the epithelial sodium channels, and which will lead to sodium deabsorption and development of hypertension. So how does the body respond to the salt consumption that we do in the daily life? So other than the renovascular and the neurohumoral system, various other systems also play a very important role, like the GI tract, the vascular system, even the skin also plays a very important role in maintaining the salt homeostasis. So this, after the absorption of the salt, this salt, how is it compartmentalized, was first described by Guyton and his co-workers, where he described that in the salt that is there is distributed and the homeostasis is maintained by the two compartment model. This two compartmental model basically says that the extracellular volume is mainly compartmentalized into two compartments, the interstitial and the plasma compartment. But then later on it was seen that in spite of in spite of keeping the salt consumption constant, the people are showing variable urinary sodium excretion. So why was it? And then came the role of the three compartment model. This idea came up when, as I said, where there was wide variation in the sodium excretion in spite of giving a constant amount of salt. So what is this third compartment? Basically this third compartment is the tissue sodium, where the sodium is stored in the non-osmotic form. Coming in detail about this non-osmotic storage. This non-osmotic storage basically the salt, how does this sodium reaches the skin and the tissues we'll see first. When we consume salt, it first enters through the GI tract, it will enter into the blood vessels. If we consume normal amount of salt, it will remain in the blood vessels and will not enter it much into the skin. But if we consume excess amount of salt, it will pass through the endothelial cells and will reach into the skin. Now, how is this salt rendered osmotically inactive? When it reaches this skin, it binds to the glycosaminoglycans, where the sulfhydryl group and the carboxyl group of the glycosaminoglycans will neutralize this positive charge of sodium and it will stored in a non-osmotic form. So, whenever there is salt depletion in the blood, what happens is these glycosaminoglycan levels in the skin will decrease, and thereby there will be release of sodium from the skin into the blood so as to maintain the blood sodium levels normal. And opposite will occur when the salt levels in the skin in the blood will increase. So whenever they will increase, there will be increased production of these glycosaminoglycans in the skin, and it will cause increase in the storage of sodium in the this third compartment. So how is this sodium regulated in the skin? In the skin, when there is excess of sodium, it will stimulate the mononuclear phagocytic cells. It will increase the tonicity enhancer binding proteins. These are the NFT5s, which will stimulate the vascular endothelial growth factors. These vascular endothelial growth factors will cause the lymphatic proliferation and will remove the excess amount of sodium in the skin via the lymphatics. Secondly, it will also cause the stimulation of epithelial nitric oxide synthase. This epithelial nitric oxide synthase will then cause increased production of nitric oxide and vasorelaxation, thereby enhancing the ability of the vessels to remove more sodium from skin. So, pathophysiology of hypertension. There are various modifiable and non-modifiable risk factors that contribute to development of hypertension in any individual. The various non-modifiable risk factors include age, ethnicity, sex, and genetics, and the modifiable risk factors including body weight, the daily physical activity of the individual, salt intake, and smoking. The pathophysiology of sodium hypertension has been nicely depicted in this schematic representation, wherein we can say that sympathetic nervous system and RAS is what plays the central role in overall pathophysiology of developing hypertension. Now coming to some more details about physiology of salt-sensitive blood pressure. This concept of salt-sensitive blood pressure was first given in 1970s by Guyton and Coleman, where they saw that in a population there are certain members which will have increase in the blood pressure depending upon the salt intake. So this change in the salt blood pressure was parallel to the salt consumption that they did. So these patients were called as salt sensitive. And the other group which were not showing a parallel rise in the blood pressure were called salt resistant. So whatever knowledge till date we have about this salt sensitive hypertension is mostly based on the animal research. Human research are difficult because there are various physiological variations in the blood pressure that occur normally. Also there are some methodological errors for BP measurement. So how do we tackle these? So what we can do is they have advised that we can set an arbitrary cutoff, wherein after a certain amount of salt consumption, if the BP rises by that arbitrary cutoff, only then we can call the patients to be salt sensitive. Otherwise, it could be just mere physiological variation. So basically, the physiology of salt sensitive blood pressure, there is defect in either natriuresis or there is impaired anti-natriuretic suppression, which will lead to salt sensitivity. So what is the role of kidney in developing this salt sensitive hypertension? As we have already seen, salt sensitivity itself is a very complex process. So abnormal excretion of sodium through the kidneys being one of the most important factors that develop this salt sensitive hypertension. This role of kidney was first described by Dahl et al. When he transplanted the kidney of a salt resistant rat into a kidney of a salt sensitive rat, and he found that this salt sensitive rat became salt resistant after getting a kidney which was from salt resistant rat, and vice versa was also true. So how does kidney play important role? As we have already discussed, the distal nephron plays a very important role in fine tuning, and where there comes the role of epithelial sodium channels. These normally epithelial sodium channels are covered by a layer of glycocalyx. This glycocalyx will not allow the much of the sodium to interact with the epithelial sodium channels. But when we consume high amount of sodium, what will happen is this glycocalyx layer will be broken off, and they will interact with the epithelial sodium channels. It will lead to cytoskeletal stiffening. So because of the cytoskeletal stiffening, there will be decrease in the release of epithelial nitric oxide synthase, and there will be decreased nitric oxide. So vasorelaxation effect will be also lost. Other than that, aldosterone that is stimulated in the salt sensitive individuals, it will act on the epithelial sodium channels, and there will be more recruitment of these channels into the epithelial surface, thereby getting more sodium interaction, more sodium reabsorption. So role of renin-angiotensin system in developing the salt sensitive hypertension has been studied extensively in the animal models, and it was seen that in salt sensitive animals there is a blunted renin response to salt depletion, whereas the depression of the renin levels that should normally happen after salt loading, this is also blunted in these individuals. This was the characteristic phenotype of a salt sensitive animal. So overall RAS as well as the local RAS also plays a very important role in developing salt sensitive hypertension, which was seen in an animal models where they saw that if the renal angiotensin type 2 receptors are deficient in an animal, they are prone to develop hypertension. But if the angiotensin 2 receptors are absent anywhere systemically, like in the heart or in the vessels, they are not showing the same response. So there is where the role of local renal angiotensin system playing important role in salt sensitivity came up. So aldosterone stimulation and salt sensitive hypertension. After there is activation of these angiotensin receptors, the aldosterone levels increase in salt sensitive individuals and thereby causing salt sensitivity. But in certain experiments, it was also found that certain animals had low aldosterone levels in spite of giving excess of salt. So what is that factor that caused increase in the salt reabsorption in these animals? And it was found that RAC1 was that factor. So RAC1 is basically a member of row family of GTPases. These have diverse biological function in the form of cell proliferation, cell differentiation, cell adhesion, but their main role in the renin-angiotensin system was stimulation of the mineralocorticoid receptors. By stimulating these mineralocorticoid receptors, they will cause more sodium retention and making the people more prone to develop hypertension. The role of sympathetic nervous system. Normally, individuals, when they consume excess amount of salt, there will be reduction in the catecholamine levels. The renal natriuretic effect, there will be stimulation of dopamine, which has a natriuretic effect. Other than that, there will be inhibition of the renal norepinephrine. But in salt sensitivity individuals, what is happening is exactly opposite of what happens normally or in salt resistant individuals. So there will be impaired salt excretion. Also, there will be increased sensitivity to the catecholamine levels, to the catecholamines that have increased, rendering these patients salt sensitive. So basically, when there is salt excess, what happens is there will be the development of lot of reactive oxygen species, especially in the central nervous system. The reactive oxygen species will stimulate the central sympathetic nervous system, which will then stimulate the local RAS, local sympathetic and local RAS system. By acting on the various receptors, this sympathetic nervous system will bring about its effect. By acting on the alpha-1 receptors, it will bring about the proximal tubular reabsorption of sodium, and will act on the beta-1 receptors to cause renin release. By acting on the beta-2 receptors, they will basically increase the sodium absorption by acting on the sodium chloride cotransporters. Other than these two major systems, some amount of role is also played by the atrial natriuretic peptide. Normally what happens is when we consume excess of sodium, this atrial natriuretic peptide will be stimulated and it will increase the sodium excretion. But in salt sensitive individuals, it is seen that these atrial natriuretic peptide levels are also low. So there will be no adequate natriuresis. Also, it has been seen that some individuals will have deficiency of this natriuretic gene itself, so they will not produce the atrial natriuretic peptide. This physiology was more seen in the black individuals as compared to the whites. So what are the various environmental and demographic factors that play a role in developing this salt-sensitive hypertension? So it is, from various studies it is seen that women are more prone to develop salt-sensitive hypertension as compared to male. Obese individuals are more prone. Intrauterine malnutrition plays a very important role. Older individuals, black population, hypertensives, and people consuming a low potassium and a poor quality diet are more prone to develop salt-sensitive hypertension. So female sex is a major risk factor for developing salt-sensitive hypertension. So various studies like the DASH study, the GenSalt study, the HyperPath study, and the InterSalt study, they all have shown that female are more salt-sensitive as compared to male. So what is the basic pathophysiological mechanism? Why females are more prone to develop salt-sensitive hypertension? So three basic pathophysiological mechanisms is increase in the aldosterone production. So in this aldosterone production is increased because of the estradiol levels that are present in the premenopausal females. Other factor is the recruitment of these mineralocorticoid receptors on the endothelium, which is brought about by the progesterone. So when in the premenopausal female, this progesterone will bring about increased mineralocorticoid receptors. So there will be more sodium absorption. Second, the third thing is the increase in the adrenal cell proliferation. So this adrenal cell proliferation, testosterone has an inhibitory effect on this adrenal cell proliferation, which is not seen in females. So they will be having increase in the cell proliferation. So coming to the role of obesity in developing salt-sensitive hypertension. So excessive visceral fat and obesity, these are already seen that 65 to 75% of the individuals are hypertension because of their obesity. So what are the various contributing factors? First thing is the physical compression of the visceral fat itself on the renal system. Secondly, the RAS activation, enhanced sympathetic nervous system activity, and high levels of leptin. So there are certain, in obese individuals, there are certain aldosterone releasing factors which will cause the release of aldosterone from the adrenal glands, and it will act on the mineralocorticoid receptors and cause salt-sensitive hypertension. So what are these factors that are present in the obese individuals that cause salt-sensitive hypertension? These are the epoxy octadecanoic acid, which is E code, and the other factor is the complement C1q tumor necrosis factor related protein, so CTRP. These are the two factors which will cause the aldosterone release in obese individuals. So role of the sympathetic nervous system is same as the role in general individuals, as in the salt sensitive individuals. Basically they will act on the alpha receptors and they will cause the increased sodium reabsorption and decrease in the renal blood flow. By acting on the beta receptors, they will stimulate the sodium chloride co-transporter and will increase the sodium reabsorption. So this is to summarize the whatever the obesity has an effect on salt sensitivity and hypertension. So basically it will cause inflammation. Salt will act on the RAC1 where the leptin and the nuclear factor kappa beta and the reactive oxygen species, all they will mainly act on the renin-angiotensin system and the sympathetic nervous system. By activating the ENaC and the sodium chloride co-transporter, they will cause increased sodium retention and salt sensitivity. Other factor that plays role in the obese individuals is hyperinsulinemia. This hyperinsulinemia, which is there in the normal individual, will bring about two effects normally. It will increase the sodium reabsorption, and secondly, it will also bring about vasodilatation. So they will be neutralizing the effect of whatever sodium is being absorbed. But in salt sensitive individuals, this vasodilatation effect will be lost, and so whatever salt is getting absorbed, along with the loss of this vasodilatation effect, that will lead to development of hypertension in these individuals. Now there is some developmental origin of Dohard hypothesis, which is called developmental origin of health and diseases, which was first studied by the Barker and colleagues. They saw that every organ system and the function is related to some fine tuning and the nutrition that is the fetus receives during the intrauterine life. So if the female who is pregnant is malnourished during the pregnancy, there will be decrease in this 11 beta hydroxysteroid dehydrogenase type 2, which is the main placental barrier, and it will not allow the maternal glucocorticoids to enter into the fetal circulation and have its deleterious effects. So basically, when a pregnant female is on a low protein diet or is exposed to dexamethasone, it will decrease this barrier, that is the 11 beta hydroxysteroid dehydrogenase, and it will cause a glucocorticoid excess in the fetus. And through various epigenetic mechanisms, it will lead to increasing the sympathetic activity in the fetus, rendering them more prone to develop salt-sensitive hypertension. So what next, coming to the role of gut microbiome in developing salt-sensitive hypertension. So whenever the gut microbiome is exposed to excessive salt, what happens is there will be certain alteration, that will be there will be decrease in the lactobacillus levels, and which will lead to decrease in dose. This will stimulate the dendritic cells that is present just beneath the epithelial cells, which will release various pro-inflammatory cytokines, and these pro-inflammatory cytokines will ultimately cause endothelial dysfunction and increase renal sodium reabsorption, causing salt sensitivity and hypertension. So the role of immune system we discussed briefly. Now we'll come in details. The hypertensive individuals various pro-inflammatory effect of angiotensin 2 aldosterone. It will act on the brain and it will stimulate the sympathetic nervous system, which will lead ultimately to tissue damage, including the endothelial, and the renal damage will lead to formation of neoantigens. And these neoantigens basically lead to development of and proliferation of the T cells and the various pro-inflammatory cytokines, leading to increase in the blood pressure. So salt, this covers in a little bit more details. The high salt consumption or angiotensin 2 basically will cause tissue damage. Various pro-inflammatory cytokines will act, and it will cause damage to the blood vessels and the kidneys, leading to increase in the blood pressure, further leading to organ damage and giving rise to a cascade. Now, how does aging affect salt sensitivity? So with age, as we know, the renal hemodynamics have changed a lot. With the advancing age, there is decrease in the renal function. Also, there is a substantial decrease in the renal blood flow. But the glomerular filtration is preserved, so the filtration fraction will be increased in these patients. The main role of sodium reabsorption will be played in these individuals by the proximal convoluted tubules. The RAS, acting via the nitric oxide, is thought to be responsible for alteration in this renal hemodynamics. So other than the effect on the kidneys, aging will also take a toll on the vasculature. So what happens with aging is that there is an increase in the arterial stiffness, there will be increase in the smooth muscle proliferation, and also there will be reduction in the availability of nitric oxide. All in all, this will develop to increase in the peripheral vascular resistance in the elderly individuals, leading to hypertension. So a new molecule was discovered around in 2015-2016, where they saw that marinobufogenin, which is a sodium pump ligand, which binds to the alpha-1 isoform of sodium-potassium ATPase pump, and it will increase basically the sodium. It will inhibit the sodium-potassium ATPase and will act on the kidney, heart, and the arteries, predisposing them to develop hypertension. So how do we diagnose these cases of salt sensitivity? So the scientific statement by the American Heart Association says that there is no definite criteria no standardized criteria for saying that the individual is salt sensitive. Around 30 to 50% of the hypertensive and 25% of normotensive individuals are salt sensitive. There are two methods that are given up for testing the individuals to be salt sensitive or not. Basically, the outpatient dietary protocol and the inpatient acute protocol. So in the outpatient dietary protocol, which extends over 2 weeks, we give a dietary variation of sodium. So we expose the individuals to a high salt and low salt diet, and we take a meticulous record of their blood pressure along with office and the ambulatory blood pressure, and we see the response along with the varying salt consumption. Whereas in the inpatient acute protocol, which extends over a period of 3 days, we initially locally load the individuals with sodium or salt, either oral or IV, following which we give the individuals furosemide or simultaneous along with simultaneous salt restriction, and it will lead to and we see the response to this treatment. The outpatient dietary protocol is said to be a more preferred one, and it is a method as we see called as a reference method. Various advantages, like the patient will not have to get admitted, there will be no IV injections, there will be just dietary salt modifications with it, though it is a time consuming process. So what exactly we do in this reference method is we give 1 week of low sodium diet and 1 week of high sodium diet. The order of which can be depending upon the objective of the study. What do we want to see in that individual, we'll decide which sort of diet to give first. After that, we take a meticulous records of the blood pressure, both ambulatory and office blood pressures, and certain cutoffs are set wherein the rise of MAP by 3 to 5 millimeters of mercury in normotensives is said to be salt sensitive, and the cutoff for classifying hypertensive individuals as salt sensitive was more than 8 to 10 millimeters of mercury. So any test which needs to be applied to clinical practice should have high reproducibility. So it was seen that even in classifying the individuals as salt sensitive or salt resistant, it was seen that these protocols, the outpatient protocol had a better reproducibility as compared to the inpatient acute protocol, which is seen over various studies. So now which diet to give first, high salt or a low salt diet for testing any individuals as salt sensitive. So American Heart scientific statement, they have said that for testing for salt sensitivity, give high salt diet first. So why do we want to give high salt diet? This high salt diet will cause activation of the renin-angiotensin system, which will suppress the renin-angiotensin system uniformly. So whenever we are giving a low sodium diet after this, there will be uniform increase in the RAS activity, which will be detected and will help us to know whether the patient is salt sensitive or not. So now, as we said, depending upon the objective of the study, if we just want to classify the individual whether he is salt sensitive or not, just randomize the individual, give him high salt or low salt diet. If you want to study the mechanism how salt loading causing hypertension, give him a low salt diet first. If you want to see how a salt restriction is causing reduced blood pressure, you give him a high salt diet first. So what are the other methods of diagnosing? We measured this non-osmotic sodium storage by using a MRI. This sodium MRI has been there in practice in several years, has been studied in various studies, wherein it has shown that when the salt sensitive individuals have an increased storage of sodium in the third compartment that we have seen, that is in the muscle and the skin. So from this study itself, they have also said that this sodium storage will be higher in men, it will be more in the elderly than young, it will be more in hypertensive, and it will be more in pre-dialysis individuals. They had coupled this sodium MRI along with the proton MRI to also see the water content of the tissues. So chemical analysis was also tried. Chemical analysis, though studied sparsely, it was also tried. So inductively coupled plasma optical emission spectrometry, that is ICP-OES, was thought to be highly sensitive but were not very widely evaluated for the same. Another chemical analysis that was tried was sodium potassium ratio in the skin, but it was not found to be very useful. As in overall hypertension, there are various impacts of salt sensitivity that can cause various end organ damage in the form of involvement of the cardiovascular system, the neurological system, also the visual system, that the ophthalmological system in the form of retinopathy. Coming to management of the salt sensitive hypertension, there is no definite management strategy for managing the salt sensitive individuals at present. Greater understanding of the risk factors is required to understand what is the root cause of this salt sensitive hypertension, and to manage those root causes is what should be the aim. The population based educational practices along with the standard of care therapy is what is thought to have a major impact. So what are the possible roles of dietary modifications? The WHO report recommends the daily salt intake of less than 5 grams per day, and NICE guidelines also recommend less than 60 millimoles of sodium per day. In a recent systematic review, which is seen that if the salt restriction is if the salt intake is less than 100 millimoles per day, the average decrease in the blood pressure would be 7/4 millimeters of mercury. Even in the DASH strategy, it is seen that in that study it was seen that dietary salt restriction when applied, it led to decline in the blood pressure both in the hypertensive as well as in normotensive individuals. Basu et al. They gave a mathematical model of depending upon this dietary salt intake, blood pressure and subsequent major adverse events that occurred. So they said that if the dietary salt is reduced by 3 grams over 30 years in India, there could be decline in the number of cases and deaths by 4 lakh and 81,000 respectively. So, and any antihypertensive that has been tried, one is there. Azilsartan has been tried in the mice model where they had, it was tried in Japan, where the subtotal nephrectomized mice they were divided into two groups. So one group was given azilsartan and the other group was given candesartan. And they found that after 2 weeks, azilsartan showed significantly lowering of the blood pressure along with a higher urinary fractional sodium in solution and reduced salt sensitivity. So what are the future prospects? We need to study the root cause of the individual's practice for the salt sensitivity. We need to form certain modalities for diagnosis that are less time consuming and equally reproducible as that of the reference methods. We need to build our armamentarium for tackling this issue of salt sensitivity. Thank you.
Questions from the audience?
You want to make a comment?
Excellent presentation. I have two questions. One is normotensives also, they can be salt sensitive or salt resistant.
Yes.
So preferably one should be salt sensitive or salt resistant.
Sir, if we know the cause that the individual is salt sensitive, we will be able to manage it. Rather than managing an essential hypertension which we don't know what is causing it, if we know that the individual is salt sensitive, we can just tackle by reducing the dietary salt in the individual. That will help in better management of this patient along with the standard of care therapy that we are already giving them.
And second is what you mentioned about the interstitious sodium content.
Yes, sir.
So how it correlates with the salt sensitivity or salt resistance? Can you?
So these individuals are, if we have a greater amount of sodium, when the individuals are salt sensitive, this mechanism itself is at flaws. So these monocytic macrophages that we have discussed, they will not take up the sodium into the interstitial tissue if the individual is salt sensitive. Whereas if the individual is salt resistant, they will be taken up into these tissues and they will be stored there. And they will be stored in the non-osmotic form. So they will not contribute to increasing the plasma volume and they will not render these individuals to be hypertensive. So if there is increase in the sodium storage, these individuals will rather be normotensive, not contributing. If we neglect the other factors that will be contributing. So if we consider only salt sensitivity in picture, if there is more interstitial storage, that will be beneficial for the individual basically. And if it will be less sodium storage, it will cause the individual to be more salt sensitive.
And how the potassium intake affects salt sensitivity?
So basically there is a potassium switch mechanism that is there in the kidney. So whenever there is a decrease in the potassium intake, it will stimulate the sodium chloride channels in the distal convoluted tubule and it will cause increased sodium reabsorption from there. So that is, this potassium switch is what is going to cause the individuals to have more sodium reabsorption and more rendering them more salt sensitive. So that is the mechanism.
Nikhil, excellent overview of the subject. Dahl actually started this whole thing about salt sensitivity. Do you think that it is relevant to humans? As far as practical management of hypertension is concerned, do we have to look at whether a person is salt sensitive or salt resistant? On day-to-day practice, I don't look at my patients, is he salt sensitive or is he salt resistant? So why do you think this topic is relevant at all to day-to-day management of hypertension in our clinic?
So salt restriction is something that we can easily advise the individual. It doesn't cost anything to them and it is very easy to be applied in a day-to-day practice by any individual. So even if the patient is considering the patient whether it is salt sensitive or salt resistant, if we restrict the sodium consumption and it is going to decrease the blood pressure of the individual without causing them an extra cost, I think that will definitely.
That's exactly what I'm saying. So there is no point in distinguishing a person as salt sensitive or salt resistant because salt is an important element which increases blood pressure. There is huge epidemiological data irrespective of whether you are salt sensitive or you are salt resistant. There is a progressive, as you increase the salt, the epidemiological data suggests very heavily in populations that those who take higher salts have higher blood pressures and complications. Japan is one such country, where there is an aborigines in Australia is another. country where there is enough data to suggest that salt intake is associated with this. But salt is definitely a controversial topic in hypertension. There are many people who believe that salt doesn't do anything to the hypertension, but many of us who believe, like you, believe that salt is important, and I think it is important. There's no doubt it helps us in day-to-day practice itself. But I'm not sure whether the salt sensitivity which started by Dahl in salt-sensitive rats, and so these were genetically rats. They had a group of rats had salt sensitivity and they had high blood pressures, and the others one was salt resistant. But in humans, in day-to-day practice, I haven't applied this to this. So is it important? I would reduce salt in everywhere, and especially in patients who are not responding to treatment. I think I would always look for that this guy is probably taking large amounts of salt. Adding a diuretic, that's what is resistant hypertension. Unless you have a diuretic, you wouldn't label somebody as resistant hypertension. Is also based on some of the things that you talked about. And I think that's, from that perspective, it is important. But I am not so sure whether I would look at person, is he salt sensitive or is he salt resistant?
So, two things which I would like to add would be that salt sensitivity, apart from its role in hypertension, it has been shown that irrespective of its role in hypertension, has an implication on cardiovascular disease and morbidity and mortality. Like even normotensive patients who are salt sensitive, because of their effects on mineralocorticoid receptors and glucocorticoid receptors, they have higher mortality. And studies have shown that it increases the risk of proteinuria and end organ damage like LDH also. Probably that is one clinical implication. Other thing would be that we usually tend to measure 24 hours urine sodium, just to check that if the patient is taking a restricted salt or not. This concept of non-osmotic sodium will probably make it difficult for us to estimate if the patient takes or does not take sodium. And one of the studies, it had also shown that nearly 50% of the individuals, even if the salt intake varied by nearly 3 grams, the 24 hours urine sodium was not different. So this is something which probably we will have to keep in mind when we are estimating a 24 hours urine sodium. Otherwise, I think, as you told, sir, not much implication for us. We always advise for a salt restricted diet.
Sounds good. So I think thank you for the talk. Oh, sorry.
Just a comment. So say this salt sensitivity is also important to understand the mechanism of hypertension as such. So as I said earlier, we believe that the hypertension is sustained because of renal reasons. But there is a group of people who will say, no, it's not just renal, there are other mechanisms also which can lead to salt sensitivity in hypertension. And that's where this direct vascular effect, which you have mentioned, and non-osmotic storage of sodium in the skin has come in. So these are independent of renal mechanism. That's how people may develop hypertension, or it may contribute to hypertension if not solely responsible for hypertension. And as Dr. Arun Kumar has said, people who are salt sensitive, there is a subgroup of people and they are more prone for complications or target organ damage. So that is also one of the predictor of outcome in these patients. Thank you.
Sounds good. Thank you. And we'll go on to the next speaker. Is hypertension a cause of ESRD? What is the evidence? And we'll have Dr. Shashank.
Good morning everyone, myself Dr. Shashank. I am going to talk about is hypertension a cause of ESRD, stage renal disease, and if it is, what is it? And my mentor is Dr. Manju. So I will be talking in the following outline: venous versus victim, initiator, promoter, animal epidemiological kidney biopsy and kidney donor evidence, and counter view of my presentation. So starting with this is the CDC slide which is showing how the chronic kidney disease is important to us, and
around 1 in 7 people in US and 1 in 5 people in US develops chronic kidney disease and hypertension leading to chronic kidney disease. Why? What is the global scenario of this hypertension contributing to chronic kidney disease? As you can see in this slide, the gray bar is showing the patients getting renal replacement therapy, and the right part in that gray circle is showing the hypertension leading to ESRD, leading renal replacement therapy. So as you can see, the European, Japan and US data, around 14%, 14.7%, around 30% of hypertension leads to chronic kidney disease needing renal replacement therapy. Going back to the previous scenarios, as this is a hypertension journal's article from 2003. In the first figure, we can see the prevalence of chronic congestive heart failure from 30 years from 1970 to 2000. And I want you to concentrate on the last two columns, black and the grey one. As you can see, in the black and the female population, there is an increase in the prevalence of the congestive heart failure from 1990 to 2000. As there's a saying that as we got to the better control of the hypertension from 1990s to 2000, there was increase in the longevity of the people, and from that we started seeing increase in the incidence of the ESRD from those populations, because population started living longer. They were no longer exposed to the hypertension, and as a result they started having kidney damage. As we can see in the second slide, from 1990 to 2000, there is increase in the incident of the ESRD and increase in the hypertension leading as a cause of the ESRD. The same can be seen. This is a slide from the Japanese treatment data from 2017, and we have to concentrate on the pink line and the brown line. Brown line shows the incidence of the diabetes leading to ESRD, which is progressively increasing from 1983 to 2017, and the pink line showing the hypertension, which is again leading and should be increasing as a cause of ESRD from 1983 to 2017. So coming to Indian data, this is Indian CKD registry data, which was published in 2012, and around 50,000 people were included, among which 70% were males, and average age was 50 years, and the kidney biopsy was done in around 2% of patients. And in this data, diabetes mellitus was found to be the most common cause of the chronic kidney disease, but hypertensive nephrosis contributed to around 13%. As we can see, the Indian was divided into 4 parts: north, east, south, west, and the hypertension leading to ESRD varied from 13 to 15% in the Indian groups. This is ICKD data from PGH Chandigarh, and this studied around 4,000 patients, among which 67% were males, average 50 years, median GFR around 40, and the kidney biopsy was done in around 17% of patients. In this study also, diabetes was the most common cause of the ESRD, and the hypertension contributed to around 8%. And in males and females, it was almost similar, 7 to 8%. This study also compared their Indian cohort with other cohorts from the other countries. The first column showing the ICKD from the Indian data, CRIC from the US data, CKD JAK from the Japanese data, GCKD from the German data, CAN-PREDICT from the Canadian data, C-STRIDE from the China data, no CKD from the Korean data, and the Nephrona from the Spanish data. These were the different cohorts of the CKD population from different countries, and as you see, the major cause of CKD in this population, hypertension, varied from 8% in India to around 27% in Canadian population as a cause of ESRD. Now coming to which one is a villain and which one is a victim. Hypertension is a villain or kidney is a villain. Let's review that. So there have been the relation is very old. It goes around around 200 years back, and to Dr. Richard Bright, who first discovered that heart and pulse is related and renal damage are both related. And in 1986, he found a correlation association between the cardiac hypertrophy and the shrunken kidneys. This was followed by a monograph in around 1914, when Dr. Bohard and Dr. Farr classified the renal histology findings into 3 parts: degenerative diseases, inflammatory diseases, and arteriosclerotic disease. And they first coined the term nephrosclerosis due to hypertension. Then in 1960, Dr. Goldblatt first questioned which comes first, which one is the villain or which one is the victim, whether hypertension comes first or whether it is kidney and vascular damage which is causing hypertension to cause more kidney damage. So as we all know, the kidneys, hypertension and heart, they are all correlated and one affects the other. So let us review the data of the animal and epidemiological studies to understand better. Second point, which one is the initiator and which is the promoter? Which one acts as the initiator and promoter? So hypertension, as you all know, in CKD controlled hypertension, it decreases the progression of chronic kidney disease. Whereas uncontrolled hypertension in patients having renal insufficiency, it causes progression of kidney disease. But uncontrolled hypertension in patients having normal renal function, whether it causes CKD or does not cause CKD, whether it acts as the initiator or not. So coming up to starting with animal evidence studies. So there has been 2 animal models to a study of hypertension leading to ESRD, dull rat and spontaneous hypertensive rat. So dull rat has been divided into 2 salt sensitive and salt resistant rat, which has been already been discussed. So in salt sensitive rat, there is an increased salt intake which leads to increased aminocorticoid receptors, increased ENaC channels, finally leading to increased sodium reabsorption and hypertension. And this one, second model is spontaneous hypertensive rat, when the control of this rat was Vistar Kyoto rat. In this model, it was found that this spontaneous hypertensive rat becomes hypertensive without exposure to the salt. And when these rats were biopsies, the biopsy were evident of hypertensive nephrocrosis changes compared to the normotensive rat. Coming to epidemiological evidence, so this was a study by Clark in 1989 when he studied around 78,000 US ESRD program beneficiaries, and he followed these patients for 10 years from 1974 to 1983. And he found that there was progressive increase. In the graph, you can see the dotted line, the second line in the below part, it is showing the increase in prevalence of hypertension, ESRD from 1974 to 1983. And when he further evaluated as a cause for this hypertension, and he found that the hypertension is increasing from 1974 to 1980. The middle line, the dotted line, showing the hypertension prevalence incidence increasing from 1970 to 1980s. Also, he subdivided this population into different age groups from 15 years to 75 years, and he found that as the age groups increases, this increase in the hypertension causing ESRD in this population. In the younger age group, glomerulonephritis were more common, but as they started aging, glomerulonephritis started decreasing, and the hypertension started taking the leading place. This one is another study by Perry et al. From 1970s. So he studied around 11,000 patients and the mean age was 52 years. He followed these patients from 15 years from 1975 to 1990. And he found that around 2% of this population developed ESRD. And there was increased risk of ESRD with high pre-treatment systolic blood pressure. And rate of ESRD decreased by 2/3 when this systolic pressure was controlled by more than 20 millimeter of mercury. As we can this figure, the X bar is showing the years from the beginning of therapy to ESRD, and the Y bar showing proportion with ESRD. And as you can see, that when the pre-treatment systolic blood pressure was more than 180 millimeter mercury, there is high risk of progression to ESRD compared to the systolic blood pressure less than 160 millimeter of mercury. This graph table is representing the risk with systolic blood pressure compared to the 15-year risk, and the first column is showing the blood pressure into 4 parts: systolic blood pressure, diastolic blood pressure, mean arterial pressure, and the pulse pressure. As we can see, when there is increase in all of them, there is increased risk of 15-year rate with progression to ESRD. This is a Japanese study published in 1996, and they health screened the Japanese healthy population. Around 1 lakh population was screened, from which 51,000 were males, and they followed these patients for 10 years from 1984 to 1994. And they found that around 2% of these population develop ESRD, and the risk of ESRD again increased with systolic blood pressure and diastolic blood pressure. In this figure, we can see the expired times from after the screening, and the Y bar showing cumulative incidence of ESRD, and the lines are showing the diastolic blood pressure. As we can see, when the diastolic blood pressure is higher, there is high risk of progression to ESRD with time. Next study comes from MRI FIT study from 1996. In this, around 3,50,000 men were screened, and from age to 35 to 57 years, and they were followed for up to 16 years. And among these, around 0.24% of population developed ESRD. And again, they found that elevated blood pressure is a strong independent risk factor for ESRD. This graph is representing the bars are representing the grade of hypertension, because it was done in the 1980 scenario, so they are staged from accordingly staged. And as you can see, the blue line showing stage 4 hypertension has comparatively very high risk compared to the other controlled hypertension patients. This one another study from 2005, and they studied the elevated blood pressure and risks for end-stage renal disease in subjects without baseline kidney disease. In this, around 3 lakhs population was screened from 1964 to 1985, all having normal renal functions with baseline GFR of around 92. And they found that around 0.36%, around 1,000 of population progressed to ESRD, and there was increased risk of blood pressure as a risk factor for ESRD. As you can see in this figure, table, the first column and the fourth column. First column showing the blood pressure category, and the fourth column showing the number of ESRD events. As there is increase in the blood pressure of the patients, the progressive number of ESRD events are progressively increasing. From optimal control from 0.11%, it has increased to around 1.32% in stage 4 of hypertension. They also found that blood pressure category, when they compared the males and females and the black and the white, males and black population were more at risk than compared to the other counterpart for progression of the ESRD. Coming to kidney biopsy evidence. So this was a study done by Fogo on the ASK trial patients. What they did, they took the 39 patients from the ASK trial, from the pilot phase, and they biopsied those patients. In those 39 patients, in 38 patients of those out of 39 patients, they found that they are having kidney biopsy evidence of hypertensive nephrosclerosis. And among these changes, the extent of glomerulosclerosis lesions correlated with the systolic blood pressure. And they concluded that renal biopsy in non-diabetic hypertensive African Americans are consistent with hypertensive nephrosclerosis. Whereas other features of nephrosclerosis, arteriosclerosis, arteriolo and interstitial fibrosis did not correlate with the systolic blood pressure. Coming to kidney donor evidence. So this was done by Doi Segil, and he screened around 1,25,000 kidney donors, and he compared followed these patients for around 25 years, and he compared the risk of ESRD early versus late. He was of opinion that when we are contemplating the data from the studies, we are following the patient for 10 years and telling them they are not causing hypertension is not causing ESRD. But studies have proved that hypertension does not cause ESRD in a short term, but in a long term it causes ESRD. So what he did, he followed this patient for a very long time to prove that hypertension in long term causes high risk compared to the in a short term. So he divided into population into two parts: early follow-up and late follow-up, less than 10 years and more than 10 years. And the median follow-up was around 2 years, and maximum follow-up was around, patient was followed for 25 years. Median GFR in this population was 98 ml per minute, and he found that around 0.2% of kidney donors develop hypertension. Cumulative incidence of ESRD increased from 10 events per 10,000 at 10 years after donation to 85 events per 10,000 at 25 years after donation of kidney. So as we can see in this table, when the patients are followed for 5 years, 10 years, 15 and 25 years, and around 70% of these kidney donors develop ESRD, and there is an increase in the cumulative incidence from 0.3 to 28.2 at 25 years. This is another donor data, and which followed around 37,000 kidney donors, and they followed them for around 12 years. And among these, we found that around 26% of patients develop hypertension, and the mean time for diagnosis of hypertension was around 15 years after donation, and the mean age at the diagnosis after donation was 56 years. And they found what they did, now they followed these patients, around 37,000 patients, and they divided the population into two parts. First part with the patient which did not develop hypertension after kidney donation, and second part which developed hypertension after kidney donation. They compared this patient whether hypertension post kidney donation is leading to ESRD or not. So they found that hypertension does lead to ESRD. Higher patients having hypertension post kidney donation have a higher risk of ESRD compared to the post donation normotensive patients. So they found that ESRD was around in 2% of patients having hypertension, and are only in 0.16% in normotensive post donor patients. Then they treated this hypertension, post donation hypertension. They treated this hypertension and compared the effect of the ACE and ARBs compared to the other antihypertensive drugs, to find that whether ACE and ARBs are having any protective effect to the progression to the ESRD. And they found that it has a protective effect for progression to SRD, and the p-value was found to be significant. Now, presenting the counter view of my presentation, and I will be dividing into 5 parts. The first will be the diagnosis. Now, we all know when the patient generally present late to us in the ESRD stage. So, nephroscopy is an easy way for classifying such a diagnosis in CKD patients. And this is data from the ETK 2017 annual registry. What they found that in the Europe, even in the single in the different countries, there is high variation of diagnosis of around 30%, when they compare the different countries in Europe. So this is a very high variation. So they are of the opinion that it is easy to diagnose CKD patients as presenting in the end stage and labeling them as hypertensive nephrosis. So somewhere we are misdiagnosing them, and that's why it could be a counter view. Second will be the renoprotective effects, which like of ACE inhibitors and ARBs. So this is the data from one of the studies which considered randomized meta-analysis of the 10 trials which were done in the earlier stages. As you can see in the first column, these studies were done from 1960 to 1980s, and all the drugs in these studies are used for the beta blockers or the thiazide, as you can see in the last column. And they concluded that patient randomized to antihypertensive therapy or more intensive therapy did not have a significant reduction in their developing renal dysfunction. But we know after 1980 we started having ACE inhibitors, ARBs, and now we have SGLT2 inhibitors. So we have a better drug to control the hypertension there, which have a renoprotective effects also. So this study is my second counter. Third part is the renal biopsy. As I have already discussed, the FOGO biopsy which was done in the ASK trial patients, and they found a correlation with the global glomerulosclerosis with the hypertension control. And this study was also done by FOGO, but they went retro back and for 11 years, and they found around 62 patients which were diagnosed having hypertensive nephrosclerosis on biopsy. And what they did, they divided this biopsy, created this biopsy changes into glomerulosclerosis, arteriosclerosis, and interstitial fibrosis. And they checked their blood pressure of those 62 patients, and then they compared those blood pressure control with the histological findings. And they found that those blood pressure was not related to the histological findings, the control of those blood pressure. So they concluded that hypertensive blood levels did not account for morphological lesions. My fourth will be the role of genetics. As we have already known, the studies support that patients attributed to hypertension nephropathy have underlying genetic defects, which has been discussed before my presentation also. And as in the African Americans, we have BOL1 and myosin heavy chain 9, which has been associated with progression of non-diabetic kidney disease in African Americans. And the last part will be the randomized controlled trials. It will not be wise to conduct these randomized controlled trials and tell the patient not to take medicine to follow them to progress to ESRD, allow them to progress to ESRD. So currently the prospective cohort studies, which has been discussed previously, provide the best and the strongest epidemiological evidence supporting hypertension as a cause of renal insufficiency. So with this, I would like to conclude, high blood pressure can harm your kidneys, take the pressure of the kidneys and your life. Thank you.
So it's open for questions from the audience.
Yes, Ajay. Can biopsy differentiate clearly, like biopsy showing CG and classical changes of chronic rheumatoid or maybe chronic interstitial nephritis, versus if you have biopsy showing clearly benign nephroclerosis or malignant nephroclerosis? Can you say with confidence that it is the cause and effect, which one is cause, which one is not?
No, sir, it's difficult to differentiate on the biopsy as hypertension lead. Only the cause of can lead to this hypertensive nephroclerosis. That's what evidence has also shown, sir. So we have to always go retrograde and check the clinical history of the patient and do some other tests also.
So after reading the literature, now what is your firm belief? Is hypertension the cause of end-stage kidney disease, or you think because is it the victim or the villain? You didn't give a comment on that, so I want, you read the whole literature. So where do you stand? It's true that you told us counter views, all other views, but what's your firm view? What would you tell? Since you are the most educated person at this point of time, so what do you think is hypertension a cause of kidney disease, or you believe that no, it could be cause for progressive damage of kidney disease, uncontrolled hypertension, but not a cause? So cause of hypertension, does it lead to ESRD?
So just like you said, salt in
Very nice.
We don't have any evidence which say it is
Good.
इसको यूक्रेन भेजना चाहिए अभी।
No, I personally would feel that I do believe, I said it earlier also, that kidney is the origin of hypertension, and I strongly believe that. And I feel if it is the origin of the kidney disease, is the origin for hypertension, then obviously hypertension has to be a cause of progressive kidney damage and as well as ESRD, chronic kidney disease and all that. So I would strongly believe that that is so. But yes, uncontrolled hypertension, from the data it gets extremely difficult to sort of say is it the cause or is it the effect, and this is what Dr. Bella was also talking about. From biopsies it gets extremely difficult to say is it an effect or is it the cause. So it is extremely, since both coexist, it's a chicken and hen question, and that's going to be always difficult to say that. But as nephrologist, I think I would also believe that probably hypertension is the cause of CKD.
Not much to say, but I've been drawing this comparison, smoker and lung cancer. So we all believe smoking causes lung cancer. Till now, there is no definitive evidence in us, but we still believe. So I don't think there's any solid evidence. It's epidemiological.
So-
It's again epidemiological, and here again it's all epidemiological. You look at hypertensives, uncontrolled hypertension, you'll find more ESRD. You look at controlled hypertension, it takes you away from congestive heart failure. It doesn't cause ESRD or let's say chronic kidney disease. And of course, it is somewhere, I mean, we all understand, and today is a reiteration of that no hypertension. So it is to begin with the cause, but eventually it becomes the victim. So it kind of travels from being the cause and becomes a victim at the end of the day. So, and I think we should believe, at least I believe, control your blood pressure, otherwise it will cause chronic kidney disease. That's where we are.
Yeah, no, I think the highlighting of smoking and lung cancer is really critical whenever you think about cause and effect, and proving it in humans or proving it in clinical context. Lung cancer is a good example to use, and smoking. So what is it that you need to prove in epidemiological data to say that this is the cause and effect? And if you look at smoking and lung cancer and all the effort that the medical community had to do to prove to the world that smoking causes lung cancer. So whether it is dose, so this is something that I hope if you go back home, look up a couple of criteria. So there's Hill and Bradford Hill criteria, as well as you can go back to the old microbiological proof, which is Koch's postulates. So Koch's postulates and Bradford Hill criteria are things that we use in clinical science to say this causes that. So going through those one by one, so the thing that you were trying to show, dose dependency. The higher the high blood pressure, the more likely ESRD. So what you're trying to show is dose dependency. A priori, so that there is a logical connection. So medical evidence, so that is medical context. So that is one criteria for Bradford Hill. And then that time. So first comes hypertension, then comes ESRD. Not the other way around. ESRD comes first and then hypertension, which also happens, but if you're trying to prove cause and effect, the cause has to come first, effect has to come later. So there are those kind of things that you have to prove and show on a repeated basis with multiple different tools. So as you were showing, you have normal people, you have donors, you have other kind of contexts, you have animal studies, and then you kind of pull it all together and you say this is cause and effect, because I have all these different evidences lining up together to kind of do it. So I think that is something that is important to see, that how do you prove it and whether these studies have done it or not. So that is something that I think is important to kind of keep in mind, and whenever you're looking at that question, going back to Koch's postulates and Bradford Hill will help guide you to kind of make those judgments of whether this study is ticking off all those points or not.
Yeah, so
Another point, or you could.
No. So I think one of the Koch's postulates was reproducibility. So that's what we cannot do with, I mean, that becomes unethical. So that's something we cannot do with such. That's our.
This is going to happen in clinical medicine day in and out. And uric acid for nephrologists is another good example. That uric acid we believe is a cause of chronic kidney disease, or is it just a bystander there and all that? And the Koch's postulate is proving makes it extremely difficult. Higher incidence in epidemiological, good correlation in epidemiological data suggests that uric acid could be a renal toxic sort of a biomarker or a marker or an agent which causes kidney disease. But reduction of uric acid hasn't done anything to the incidence or overall effects on progression. So that's where the problem.
And a flip side of believing in cause and effect, I think the best thing is estrogens and heart disease. So on the flip side, all the epidemiological data showed that estrogen was protective. Every kind of Bradford Hill was done till Women's Health Initiative came in. Women's Health study was done, randomized trial given to women on a large scale, and we found that all our epidemiological data was wrong, and it was biased on a social basis of our bias of giving medicines to some person versus the other. So just your example, the Mayo study that you showed, in which ACE inhibitors were protective. This was not a randomized trial. People, the Mayo group had their donors. Some donors had hypertension. Some of them were given ACE and ARBs. Some of them were not given ACE and ARBs. So which nephrologist or which primary care physician decided to give ACE and ARB? And did they follow them more closely? Because now this is a bias interaction. So people, doctors who give ACE and ARBs to their donors who have hypertension probably are monitoring them more closely, probably are taking care of them, and so they didn't develop ESRD. The other donors were left on their own, not given ACE and ARBs, and they ended up with ESRD. So now, because this is not a randomized study, so bias of how we look at it and what we did, because these are cohort studies, so those are kind of things that can also play into it. And we have previous evidence of causing damage and doing that. So that's something I think which is important to keep in mind. Thank you. So we'll take on the next speaker. So the next one is definition of hypertension, how to measure role of home blood pressure and ambulatory blood pressure monitoring, and Dr. Harley.
Good afternoon, everyone. My topic is hypertension, its definition, its measurement, and the role of ambulatory blood pressure monitoring and home blood pressure monitoring. So as we all know, the definition of blood pressure, it is the lateral pressure that is measured in millimeters of mercury and exerted by the flowing blood in the walls of the arteries. It has two components, namely systolic and diastolic blood pressure. Systolic blood pressure is the maximum blood pressure during the contraction of the ventricles, and diastolic is the minimum pressure in the arteries recorded just prior to the next contraction. So, can it be generalized? So, elevated blood pressure is a trait as opposed to a specific disease and represents a quantitative rather than a qualitative deviation from the norm. So, any definition of hypertension is therefore arbitrary. Hence, cutoff points are taken for operational feasibility. So a practical definition of hypertension would be the level of blood pressure at which the benefits of treatment would outweigh the costs and the hazards. So hypertension, as we all know, dominates the global chart for leading risks of death. It is a leading risk factor as according to the global burden of disease. It is associated with 69% of MIs, 74% of coronary heart disease, 77% of first strokes, and 91% of heart failure. So at least 1 out of every 5 adult Indians, as far as the Indian scenario is concerned, has prevalence of hypertension. It is responsible for 57% of all stroke deaths and is responsible for 24% of all coronary heart disease deaths in India. So let me take you through the chronology of the various hypertension guidelines that have been developed over the years for its diagnosis and management. So out of all of them, the two most prolific which have been adopted and are being used are the US guidelines and the European guidelines. So US guidelines were first introduced in 1977, updated in 2003 when they termed the coin pre-hypertension, and now the latest that we are using are the 2017 AHA guidelines, where the threshold of diagnosis of blood pressure has been reduced to 130/80. European guidelines were first released late in 2003, then periodically updated in 2007, 13, and now 2018. They have not altered the threshold of diagnosis of hypertension as more than equal to 140/90. So now we have International Society of Hypertension, which first published its guidelines in 2014 and now updated in 2020, keeping in mind the scarcity of resources in middle and low income class countries. Then we have the Asian guidelines, including the Indian guidelines, which have also been released in 2019. So now this is a comparison of the two most prolific guidelines, that is the ACC 2017 and the European Society of Cardiology 2018 guidelines for diagnosis of blood pressure. So according to the ACC 2017 guidelines, the definition of hypertension is taken as equal or more than 130/80 of blood pressure. Whereas in the European Society Cardiology guidelines, the blood pressure threshold is taken as more than equal to 140/90. The ACC guideline divides blood pressure into normal, elevated, and stage 1 and 2 of hypertension, whereas the European Society Cardiology guidelines divides it into optimal, normal, high normal and 3 stages of hypertension. But the hypertension definitions, wherever they may be, the BP treatment goal is the same, that is 130/80. So these are the level of blood pressure defining hypertension according to different office readings, ambulatory blood pressure monitor readings and home blood pressure mean readings. So as we can see, the American cardiology guidelines show a lesser threshold of defining blood pressure as 130/80 as compared to the European Society, which in all its parameters is showing a definition of hypertension as more than equal to 140/90. So these are the ISH guidelines of 2020, which were also on the pathway of European guidelines, which also categorized as normal blood pressure, high normal, but the stages of hypertension were categorized as grade 1 and grade 2. And these are the Indian guidelines of hypertension in 2019, which again classified the diagnosis of blood pressure as more than equal to 140/90, also on the lines of European guidelines, and divided hypertension into stages of 1, 2, 3 and isolated systolic hypertension, defined as systolic blood pressure of more than equal to 140 with a diastolic of less than 90. So these are the thresholds for diagnosing hypertension based on the different studies that I've already mentioned, that is the ACC, European, ISH and the Asian guidelines. So when we compare, the ACC has a lower target threshold of blood pressure diagnosis as compared to the other guidelines, the ESH, ISH and the Asian. So the reason that the AHA recommends a lower diagnosis of blood pressure is because of consistent epidemiological evidence as well as several meta-analyses which have showed that a blood pressure of between 130 to 139/80 to 90, these patients are already at a 1.5 to 2 times higher risk of coronary and stroke events as compared to systolic blood pressures of below 120. Also, the SPRINT trial might have a role in formation of lower thresholds of diagnosis of hypertension in the ACC guidelines, where hypertensives who were treated more intensively to achieve a lower BP target of less than 120 had a more reduction in CV mortality than a blood pressure of less than 140/90. So blood pressure measurement, method of blood pressure